So we embarked on this project to develop a vision for the future of the delivery system in Medi-Cal and establish a pathway to reforms. And one of the things that you discovered in this was that there was already a vision articulated and general consensus around that vision. Can you say a bit about what that vision is?
The vision, I think, for which there's a good amount of agreement is that there be an accountable, coordinated system of care, that there be adequate and stable funding, and that there be strong state leadership to move the program forward. Where we were surprised, I think, is to find that a really large share of the stakeholders that we interviewed felt that going along business as usual was not going to get them to that vision, that there really needed to be some deeper conversations about some of the structural barriers that prevented California from achieving that vision.
Were there any surprises to you in what you learned about California in conducting this work?
There were. Obviously, a lot of the challenges that California's Medicaid program faces are common ones around the country, where there's so much change going on in the marketplace, so much focus on trying to drive value and to deliver better care, but also some of the nuances make California unique. For example, the division around behavioral health and physical health is embodied in some respects in California in its state constitution. So while we see those divisions in financing and in systems in other states, the ways in which some hands are tied is pretty unique to California.
We also heard about some of the cultural differences between the physical healthcare system and the behavioral health system. Is that something that is unique to California, or you find in other states as well?
That's pretty common, and it can make the conversations challenging sometimes about the behavioral health community concerned that it will lose the uniqueness in ways in which it cares for people. But I think the consensus around the country is that you can't argue against integration. There has to be integration. There is one patient, and the idea that the patient needs to traverse multiple systems, especially a patient that has severe mental illness, is just one that's not tenable.
Some of these issues about delegation and trust are different everywhere. Is that something that you find, is that unique to California? Is that something that you find in other states as well? Sort of the variation within a state about how the managed care and the delivery system is structured?
California's system is extraordinarily complex. It is a very large state, and so one would expect variations, and one would want variations because of the different nature of the marketplaces and the needs of the population in different parts of the state. But I think, as one panelist said, no one would design the system the way we have it today. It's evolved over time and not really kept up with the changes in the marketplace, the size of the program, the complexity of the population that the health plans are managing. So I am convinced there are ways in which California can allow for that flexibility and allow for that diversity in different parts of the state while still taking hold of the system and saying we're going to together drive for better value, keeping an eye on our beneficiary always as the center of what we are trying to accomplish.
Well, thank you and your team for a terrific work on this paper and for joining us here today.
It was a pleasure. Thank you for supporting us.